My name's Chris Khoory. I'm a fifth year. At Uni of Liverpool on GP Society, and I'll be going through vascular disease today. Can't cover everything vascular in one PowerPoint because there's quite a lot to go over. So I've gone over some topics which I think are quite important. So let's get stuck in. Right, so these are the three topic areas we're going to focus on today. So first one is AAAs, and we're going to talk a little bit about peripheral vascular disease, and lastly, acute limb ischemia, all high yield topic for exams. So starting with AAAs, so what is an aneurysm? An aneurysm can be defined as a localized area of pathologically excessive arterial dilatation. So for the abdominal aorta, a diameter of more than 3 centimeters is generally accepted as defining an aneurysm. So just a ballooning of an artery. So etiology and pathophysiology. There are various different factors which contribute towards the formation of aneurysms, abdominal aneurysms. Abdominals of the aorta, iliac, femoral, popliteal arteries, they're often branded atherosclerotic, but the primary disorder is degeneration of the elastin and collagen in the arterial wall. So if you think that the walls of the artery are going to be getting weaker, they'll start to balloon outwards and an aneurysm will result. Atherosclerosis can be found within the aneurysm, and it's likely that the two pathologies share risk factors. Around 90% of AAAs are infrarenal, so that's below where the renal arteries branch off, and that tends to make surgical repair easier. If they're above the renal arteries, surgical repair is a bit more tricky. So the etiology is unknown, but some possible causes are listed there. So things like atherosclerosis, trauma, infection, various connective tissue diseases, and some of the rarer inflammatory diseases as well. I forgot to say, if anyone's got any questions at any point, feel free to unmute yourself or drop a message in the chat and ask away, that's fine. So some risk factors for AAAs. So these are kind of all your cardiovascular risk factors, really, the same things that will increase your risk of heart attack, stroke. So being male, smoking, high blood pressure, hyperlipidemia, a family history, and age. How does it present? So there are two different kinds of presentation. There's the acute presentation. You'll typically get sudden onset, severe abdominal pain or back pain. You can get collapse and hemodynamic instability. And ALI is acute limb ischemia, which we'll get onto later in this talk. That may occur because the aneurysm can spit out emboli from the atherosclerosis down to the lower vessels of the leg and cause limb ischemia. And then there's the non-acute presentation. So it can be an incidental finding on a scan. So if someone's having an ultrasound or a CT for another indication, it may pick up an aneurysm. It can be picked up through screening, and the next slide goes over the screening program. Or it can be just through mild back pain, and as further investigations done, an aneurysm can be found. And on examination, you'd expect to feel a pulsatile mass felt in the abdomen. Sometimes you have to press quite deep to feel the aorta. So the screening program is the National AAA Screening Program. In the UK currently, all men at age 65, they get a letter in the post from the NHS saying you're invited for a one-off ultrasound scan. So studies have shown that men screened for AAAs have approximately 50% reduction in aneurysm-related mortality. And the pickup rate's quite low. It's only around 1.1%, but it's important that these patients are being picked up because the consequences, if they're not, can be fatal. So what investigations are done? So for diagnosis, it's an ultrasound scan of the abdomen. And then if an aneurysm is found, they'll then have a follow-up CT with contrast. And that's only warranted when the aneurysm size reaches 5.5 centimeters. Okay. So here's an example of a CT scan of someone with a AAA. So you can see here, so we're looking at a CT scan here. So remember, this is the right-hand side of the patient. This is the left-hand side. This is the vertebra here. You've got the psoas muscles there. This is your aorta here. This is much, much bigger than it should normally be. It should normally be about this big. The big white area here is the lumen of the artery. The reason it's nice, shiny and white is because you've got contrast. This is a CT scan with contrast, so it highlights it nice and strongly. And you can see kind of this crescent area over here, this deeper kind of area within the vessel wall that reflects atherosclerosis within the aneurysm. And then you can see here what's labeled here, calcification, little white specks in there. So you can also get calcification within the aneurysm. And here's another example here. So you can see this time the lumen is a lot smaller, but you can see that the size of the aorta is very big. So that's another aneurysm. So management. So we said that a duplex ultrasound scan is for diagnosis, but it's also for monitoring an aneurysm. So any AAA that's under 5.5 centimeters can be monitored with a duplex ultrasound scan. As surgery prior to this diameter, it's been shown that it doesn't actually provide any survival benefit. This is for either open or endovascular repair. AAAs above 6.5 centimeters require DVLA notification and disqualifies them from driving until repair. This is just because there's a high risk of it bursting and it can cause road traffic accidents if someone collapses at the wheel. But the important numbers to remember are those on the screen. So if an aneurysm is between 3 centimeters and 4.4 centimeters, they should be followed up with the annual ultrasound scan. If it's between 4.5 and 5.4 centimeters, there should be 3 monthly, so a lot more frequent. So there are various lifestyle modifications that you can make which will reduce your risk, and this is important not only to reduce the risk of a AAA getting bigger and worsening, but also to prevent things like heart attacks and peripheral vascular disease and strokes. So these are, I'm sure you'll all know these by now. It's smoking cessation, improved blood pressure, statin and aspirin therapy can also help, and weight loss and exercise. So a patient with a small AAA, so that's usually below 5.5 centimeters before it needs an operation, they have around a 3% per year risk of cardiovascular mortality. So that's why it's really important to control these factors as best you can. So getting on to the actual surgery. So if there's one thing you take home from this little section on AAAs, it's that first bullet point there. So there are 3 main criteria for when you'd consider surgery for a AAA. So this is, firstly, if the AAA is more than 5.5 centimeters. Secondly, if it's expanding at a rate of more than 1 centimeter a year. Or thirdly, if it's causing the patient's distressing symptoms, so things like back pain, which we've already mentioned. And there are two main different options for surgery. There is an open option, and there is a endovascular repair. So that's the minimally invasive option. With the open option, the patient would typically have a midline laparotomy, so big incision right down the middle of their abdomen. They'd cross-clamp the aorta at either side. The aneurysm would then be cut open and the thrombus inside removed. And then they can use a Dacron graft to sew it inside. Clamps are then removed to check for leaks. And the rest of the aorta wall is sewn around the graft, and then they close them up. So that's the open option. The endovascular repair, this introduces the graft through the femoral arteries and fixes a stent across the aneurysm. And there's a picture of it on the next slide, which I'll show you. It might be a bit easier to visualize. So regarding outcomes, which is better, open or minimally invasive, so both of them have similar long-term outcomes. The EVARs do have an improved group of short-term outcomes. So this includes things like reduced hospital stay and reduced mortality. So the mortality of an EVAR is around 1.7%. With open surgery, it's around 5.5%. So that's quite significant. However, EVAR has a higher rate of reintervention and aneurysm rupture. So a common reason for reintervention is complications of EVAR. So you can sometimes get leaks around the aneurysms. After 2 years, the mortality for both procedures is about the same. So open repair might be more appropriate for younger, fitter patients who can tolerate the major surgery a little better. Okay. So here's a picture, here's an example. So you can see in A, they're using, they are passing a graft through the aorta, and then the stent is inflated to create a nice wide lumen for blood to flow normally. So I mentioned endoleaks. So this is a very important complications of EVARs. What it is essentially, an incomplete seal forms around the aneurysm, and this results in blood leaking around the graft. It's usually asymptomatic, which is why patients usually need regular surveillance after their surgery. And there are various different types classified from 1 to 5, but you definitely won't need to know that for exams. That's quite advanced. So what happens when a AAA ruptures? So that's the big danger with AAAs really. A ruptured AAA can be very dangerous. It's a life-threatening event. Around 50% of patients reach the hospital, and of those that reach the hospital, around another 50% of those survive the emergency surgery repair. So all in all, that's around 25% of patients with ruptured AAAs will survive. So the risk increases exponentially with diameter. The bigger the aneurysm, the higher the risk. Around 50% of patients present with a classic triad. So that's back or flank pain, hypotension, and a pulsatile abdominal mass. Around 20% rupture anteriorly into the peritoneal cavity. This has a much worse prognosis than a posterior rupture, which is more common. Around 80% rupture posteriorly into the retroperitoneal space. Does anyone want to either pop in the chat or unmute themselves and have a guess why the prognosis is so much worse? Sorry, so much worse if it's an anterior rupture.
Is it because there's more space for blood to pool?
Yeah, exactly. So the aorta is a retroperitoneal structure. So if you have a posterior bleed, it will be tamponaded effectively. So blood won't continue to be free to leave the aorta. So when it's tamponaded, the risk of mass bleeding is a lot lower than if it bleeds anteriorly into the peritoneum. So yeah, that's absolutely right. So how do you manage a AAA? So your basic resuscitative measures, so high flow oxygen, IV access, you need urgent bloods, and you need to cross match a minimum of 6 units. This is because when they're going to, if they make it to surgery, the likelihood is they're going to lose a lot of blood. So you're going to need to have that blood ready to replace. Patients that are in shock, it should be treated quite carefully. This is because if you raise the blood pressure too much, it can dislodge a clot inside the aneurysm and then send that clot into the legs, causing further problems. So that's why if you suspect a AAA and the patient is in shock, you should try and keep their systolic below 100. And from there, you transfer them to the vascular unit. If they're unstable, they go straight to theatre, no messing about. You really need to fix that aneurysm as soon as you can. But if they're stable, you might have a bit more time. You can take them to CT to help determine, and it'll be the consultant surgeon's decision whether they're suitable for an open surgery or an endovascular one. So that's kind of the first part, talking about AAAs. Does anyone have any questions at all before we move on? See if I can answer them.
Who would do the endovascular surgery? Would that be the interventional radiologist or the vascular surgeon?
Generally, it is the interventional radiologist, I believe, but I'm aware that they can do it together. So the vascular surgeon can do it with the interventional radiologist. But I will double check that for you because I'm not entirely sure, if I'm being honest.
No worries. Thanks.
Okay, great. So we will move on to peripheral vascular disease now, or peripheral arterial disease. So what is it? So peripheral arterial disease, it arises when there's a significant narrowing of arteries distal to the aortic arch. So it can happen anywhere along the aorta past the arch. Different mechanisms. The most common by far is atherosclerosis. So your artery is getting full of all these horrible plaques, narrowing the lumen. Can occur with vasospasm. Raynaud's a good example of that. Or it can be inflammatory and a vasculitic type picture. It's a lot more common than one might think. It affects around 20% of people above the age of 70, but around 60% of these patients are asymptomatic. So your risk factors, exactly the same as before, your typical vasculopathic risk factors, all the smoking, being male, hypertension, high blood pressure, family history, obesity, age, but the biggest one is smoking by quite some way. And diabetes. Diabetes is a big risk factor too. So there's a classification of chronic leg ischemia called the Fontaine classification. So split into 4 stages. The first stage is when they're completely asymptomatic, no problems whatsoever. The stage 2 is when they start to become symptomatic, and this is known as intermittent claudication. Stage 3 is when they get rest pain, ischemic rest pain. That's critical limb ischemia. And stage 4 is when they get tissue loss in the form of ulceration or gangrene, or you can get both together. So it's important to have in your mind that intermittent claudication, critical limb ischemia, ulceration and gangrene, they're all the same pathological process, and they all result from narrowing of the arteries due to atherosclerosis most commonly. So just a little bit on intermittent claudication. So what is it? Claudication refers to the ischemic pain due to decompensation of the blood supply, typically occurring with physical activity. So it's important when you're talking to these patients to ask them how far they can walk before the pain starts. And that is known as the absolute claudication distance. So the longer they can walk without the pain, the less severe their pathology is going to be. If the proximal vessels are involved, you can sometimes feel pain in the thighs and buttocks, so a bit higher up. So it's important to bear in mind some differentials of things like different causes of back pain as well. So determining, as we said, determining absolute claudication distance is crucial. It's most common in the distal superficial femoral artery. So that's just above the knee, and then that will correspond to pain in the calf. So most commonly pain for intermittent claudication is in the calf. There shouldn't really be any weakness or numbness, and the pain resolves quite quickly on rest, usually within about 5 minutes. There are a few differentials, although that are important to have in the back of your mind. So one is venous claudication. This is quite rare, and it's usually in the context of DVT. And then the other differential, which we said, was nerve root pain. So it could be a sciatica type picture, such as osteoarthritis of the spine or spinal stenosis. So how do you investigate peripheral vascular disease? So intermittent claudication is a clinical diagnosis. It doesn't need any investigations, doesn't need any poking or prodding. You should be able to get that from the history. An ABPI, which stands for ankle brachial pressure index, can assist with diagnosis. So it can offer information about the severity. An ABPI should be done in both arms. So when stood up, the arterial pressure in the arms and the legs are different due to hydrostatic differences. But when they're lying down in a healthy patient, theoretically, they should be the same. But this is not the case in peripheral vascular disease. So here are some values. In this table, there are some different statistics depending on which textbook and what website you look on. Most tend to say 0.5 to 0.7, 0.7 to 0.9 instead of 0.8. But just to go over it quickly. So if it's less than 0.5, this represents severe peripheral arterial disease, and the patient is likely to have gangrene and ulceration. If it's 0.5 to 0.7 or 0.8, this is moderate disease, so they'll get pain at rest. If it's 0.7 to 0.9, that's typically when they'll get intermittent claudication. And 0.9 to, it's usually 0.9 to 1.3 normal, typically symptom-free. If it's more than 1.3, does anyone know what this might represent? Any ideas?
An error in the way they've done the measuring?
So it could be an error, in the measuring. But for exams, if you see an ABPI of more than 1.3, this is typically due to hardening of the arteries in diabetics, which is called arteriosclerosis. And the reason for this is because the arteries are poorly compressible due to the calcified vessels. I hope that makes sense, and I'm not just waffling on. So that's how you kind of assess the severity with an ABPI. So how do you manage intermittent claudication? So intermittent claudication is not surgical management, it's just medical and lifestyle. So lifestyle is the most important thing. And vascular surgeons can actually refer patients to supervised exercise groups now. Statins definitely help bring down mortality and morbidity rates. You should offer a form of anticoagulation with either aspirin or clopidogrel. Those are your doses, 75 milligrams once a day. Controlled blood pressure and glycemic control, particularly if diabetes is a big risk factor. So when it gets a bit worse, you get critical limb ischemia. Here you need to do something because the limb is at threat. Around 50% of these patients are dead within 5 years just because they'll have so many other problems going on, things like heart attacks and strokes. So critical limb ischemia can be defined as ischemic rest pain for more than 2 weeks requiring opiate analgesia. Also as the presence of ischemic lesions or gangrene and an ABPI of less than 0.5. So the rest pain that they get, it will typically be different to the pain that you get in intermittent claudication. So the intermittent claudication pain that we talked about, it's always on activity, resolves with rest, and most commonly in the calves. With critical limb ischemia, the pain is mainly felt in the toes. It's usually begins at night time, and patients will often hang their leg off of the side of the bed, which can then in turn cause swelling or swollen ankles. And then the tissue loss, the ulcers tend to occur on the dorsum of the foot, in between the toes or under the heel. They're arterial ulcers, so they're usually punched out, small and deep, and you can also get gangrene and necrosis. On examination, the limbs might be pale, might be cold, and the pulses may be weak or absent. And there are various other signs of vascular disease to look out for. So this, sorry for the gruesome picture, I should have put up a little warning there, but there's an example of a gangrenous necrotic toe that requires amputation. And you can see it has been amputated in the second picture. So how do you investigate peripheral arterial disease? So remember we said it's a clinical diagnosis and ABPI to help assess severity. Scans only really become important when planning treatment. So different options that you have, you can use a duplex ultrasound scan, and this can detect the flow and assess the severity and where the occlusion is in the vessels. The gold standard is a CTA, that's a CT angiography, but it's not very good below the knee because calcium shows up as white, and in diabetics, we said that they can sometimes get calcified vessels. So this can interfere with the readings. MRA, which is magnetic resonance angiography, it's very, very good, but it's not readily available and it's quite expensive. So CTAs are generally the gold standard. You can also do angiography with DSA. DSA is digital subtraction angiography. What this is it's essentially the same thing. So you do a scan, but then the computers take away the other tissue to just show the vessels. So here are some examples. So if you look over here on the left leg, you can clearly see that there's an occlusion over there. And then this guides surgical management. The surgeons will then be able to plan and know where to go when doing the surgery. And here's another example. So this is the right iliac artery, should be coming off here, but there's an occlusion here blocking it off. Okay. So management. So with critical limb ischemia, you do your medical management just as before with intermittent claudication. So all of your lifestyle changes, clopidogrel, aspirin, etc. And then you have different options. So you've got endovascular and open surgery. So endovascular, they can have a balloon angioplasty with or without a stent. So this is when they catheterize the vessels right to where the blockage is, They have got a little balloon, inflate it to open up the lumen and relieve the blockage, and they can sometimes leave a stent in there. And then you've got your open options. So this would be an endarterectomy. That's just opening up the vessel, clearing out all the atherosclerosis inside and closing it up. Or a bypass, such as a FEMPOT bypass, which is, a FEMPOT bypass would be, which is actually shown in the second picture here. It shows how the occlusion is being bypassed from the femoral artery to the popliteal artery. So you can use different things for this. So you can use grafts such as veins. Sometimes the saphenous vein is used. And you can various different vessels can be used to bypass the blockage. And then the last resort is amputation. So amputations are considered for any patients who aren't suitable for revascularization, with ischemia causing incurable symptoms or gangrene leading to sepsis. So if you go to any vascular wards, you will see a lot of patients with missing limbs, missing feet, because they've had to have amputations in the past, unfortunately. So that wraps up peripheral vascular disease. I hope I've explained that okay. Does anyone have any questions at all? No? Okay, right. Well, there is or isn't?
There isn't, no.
There isn't, okay. All right, we'll move on then. So the last topic is acute limb ischemia. So acute limb ischemia is a surgical emergency, and it's a completely different pathology to peripheral arterial disease that we've just mentioned. So the two processes should be completely split off in your mind. So what is it? It's defined as a sudden decrease in limb perfusion that threatens the viability of a limb. So it's complete or even partial occlusion of the arterial supply to a limb can lead to rapid ischemia and poor functional outcomes within hours. So things can turn downhill very quickly, which is why it's important to really get it under control as soon as you can. So the etiology of acute limb ischemia is classified into three main groups. So embolization, that is by far the most common. So this can be caused by things like AF, a mural thrombus after you've had an MI, a AAA, and prosthetic heart valves. The embolization basically describes where a little clot is thrown off into the arteries of the leg. You can also get thrombosis in situ. So this is where you have the atheroma plaque in the artery, and it can rupture, which then forms a thrombus on the plaque's cap. And finally, trauma, something like compartment syndrome or dissection. So the clinical features of acute limb ischemia. So these are your 6 Ps. Does anyone want to shout? You feel free to shout out some of the Ps if you know them, or put them in the chat.
Pain.
Yeah, pain's one of them.
Pulselessness.
Yeah, pulselessness. That's 2.
Pallor.
Yeah, that's 3.
We've got perishingly cold in the chat.
Yeah, perishing cold.
Paresthesia.
Paresthesia. I think there's one more.
Paralysis.
Paralysis, perfect. So they like to ask this a lot in exams, so make sure you know this presentation, the 6 Ps. So as we said, pain, pallor, pulseless, perishing cold, paresthesia, and paralysis. So the 6 Ps, and you've got 6 hours to save the limb before you get irreversible damage. And there's a visual representation of it. So the anesthesia and the paralysis are key to diagnosing complete limb ischemia, and that requires emergency surgical treatment. Pallor and pulseless may also be present in chronic ischemia. Generally, the perishing cold is quite unreliable. That's because an ischemic limb can sometimes take on the ambient temperature, so the temperature of the room. Paresthesia leads to anesthesia, which is the inability to feel touch on the foot. And paralysis, you can just ask the patient, can you wiggle your toes, just as a gross motor assessment. And there are some differentials just to bear in mind. So critical limb ischemia, acute DVT, or spinal cord and peripheral nerve compression. So acute limb ischemia can be classified. Again, you probably don't need to know this for exams, but this is just to kind of highlight the there are different severities of acute limb ischemia. So this is called the Rutherford criteria. So there are 3 different categories. There's 1 where the limb is still viable, so there's no immediate threat and everything is intact. Then you have your 2, which is split into 2A and 2B, marginally threatened and immediately threatened. So these are salvageable, but you have to act quickly. And then 3 is irreversible. By this point, it's too late to save the limb and surgery won't help. So how do you investigate acute limb ischemia? You do your routine bloods. So this includes a lactate to assess the level of ischemia, because the more ischemia you'll get, the higher the lactate will be. If they're under 50 years old without any known risk factors, you should do a thrombophilia screen, because then this may reveal a cause of clotting. You should do a group and save, again, because they might need to go to surgery or they might need some blood products, and do an ECG as well. An ECG might show underlying AF, which is a risk factor. You should do a bedside Doppler ultrasound in both limbs to assess the blood flow, and you should consider a CT angiogram as well. So we've mentioned Doppler and duplex ultrasound scans quite a bit, but I think it's quite important to go over what the difference actually is between Doppler and duplex. So a duplex, it essentially combines traditional ultrasound with a Doppler ultrasound. So a traditional ultrasound uses sound waves that bounce off of the blood vessels to create pictures. A Doppler ultrasound records sound waves reflecting off of moving objects such as blood to measure the speed and other aspects of how they flow. So a Doppler offers a bit more than just a traditional ultrasound by itself, which is why duplex are really helpful in vascular disease, because they can assess blood flow. Finally, moving on to management. So managing acute limb ischemia. Initially, you want high flow oxygen, IV access, and a therapeutic dose of heparin. This can be given as a bolus or an infusion over a set period of time, which will be in your trust guidelines. It's really important to get senior surgical support as soon as you can, because time is lim. Conservative measures may be appropriate for Rutherford 1 or 2A. This is when we said there isn't an immediate urgency and everything's okay at present. So you just need to regularly assess the patient and make sure they're doing all right. You've got surgical options, and then there are some long-term options as well. So we've really hammered home lifestyle this talk. So lifestyle really can make a difference to these patients. And then you've also got your antiplatelet agents. So that's your clopidogrel, ticagrelor, aspirin, 75 milligrams. And then occupational therapy, physiotherapy and rehab if they have an amputation. So we said surgery. What kind of surgery? So if it's embolic, they can have an embolectomy with a Fogarty catheter. This is where they introduce these little wires into your blood vessels. They inflate the balloon beyond the obstruction and then draw it back, and then that will bring out the blood clot. You can also have intra-arterial thrombolysis, so that will do its best to dissolve the clot, and then bypass surgery is another option again. If it's thrombotic, you can do your local intra-arterial thrombolysis again. And as before with peripheral arterial disease, angioplasty with or without stenting and bypass surgery are options as well. So there's the diagram which shows the catheter being inserted there. Past the blockage, the balloon is inflated, which widens the lumen. A stent can be left in place, and then the wires removed. and irreversible limb ischemia, so it will have a mottled, non-blinding appearance with hard, woody muscles. This requires urgent amputation or a palliative approach. So just last slide. So complications of the surgery. So firstly, the mortality rate is really high in acute limb ischemia. It's around 20%. It's important to think about something called reperfusion injury. So this limb that you're treating hasn't had blood and oxygen flowing to it for quite some time. So when you revascularize it with a bypass or angioplasty or all these options that we've talked about, various things can happen. So you can get compartment syndrome, and you can get release of a lot of substances from the damaged muscle cells. So you can get release of potassium, which can cause hyperkalemia. You can get release of hydrogen ions, which can cause acidosis, and release of myoglobin, which can cause an AKI. And the reason for this is you get, when you're flooding the vessels in the limb with blood and oxygen again, there's a sudden increase in capillary permeability, which can leak out into the surrounding tissue. So that kind of wraps up the main bulk of this talk. So we've just got a few questions now to see if we can consolidate what we've learned. So question number 1, a 65-year-old man is diagnosed with an abdominal aortic aneurysm with a diameter of 3.9 centimeters through the National Screening Programme. He's scanned again the following year to monitor the aneurysm, and the diameter is now measured as 5.1 centimeters. He has no symptoms from his aneurysm at the present time. What is the most appropriate step in the management of the man's aneurysm? So if you just take around 20 seconds, 30 seconds, just to jot down an answer, and then if someone, you can put it in the chat. Are you getting any answers coming up, Catherine?
Yeah, just got an answer in the chat now. Would you like it?
Yeah, go for it.
Yeah, so we've got an urgent EVAR.
Okay. Anyone else? Got any answers?
Someone else has gone for the elective EVAR.
Okay. So yeah, the second one was right. So elective EVAR is the right option here. So the reason for this is because they don't need urgent repair because there isn't any indication of rupture, but he does have a large aneurysm of 5.1 centimeters. Remember we said 5.1 centimeters doesn't meet the criteria to operate on them. However, it has increased by more than 1 centimeter in a year. So therefore it should be repaired even if it's asymptomatic, which is why elective endovascular repair would be the right option. Okay, move on to the next question. So John is a 65-year-old man who attends hospital for an ultrasound scan to screen for a AAA. It's discovered that he has an unruptured aneurysm that is 4.6 centimeters in size. What would be the most appropriate management of John's AAA?
We're starting to get some answers through again.
Okay. What have people gone for?
So we've got 2 people saying a repeat ultrasound in 3 months.
Okay, that's brilliant. That's the correct answer. So anyone who answered that, do you want to be brave and unmute yourself and say why you went for that? Or am I being a bit mean?
Do you follow the guidance? I think you, on that slide, it said above 4.5, you do 3 months. And then if it's less than that, it's a year.
Yeah, perfect. That's absolutely right. So 3 centimeters to 4.4 centimeters is annual ultrasound scan, and then 4.5 to 5.4 is 3 monthly, and then 5.5 and above they need surgery. So that's absolutely spot on. Well done. And we've got a few more questions. So a 66-year-old man reports that he is struggling to walk his dog as he finds that his calves are intensely painful after about 10 minutes. A lower limb examination is normal, aside from absent posterior tibial and dorsalis pedis pulses. His past medical history includes a myocardial infarction 3 years ago, and he also smokes 30 a day. Given the likely diagnosis, which one of the following medications should he be prescribed daily for secondary prevention of cardiovascular disease?
Getting some answers through already. Would you like to hear them?
Yeah, sure.
So we've got quite a few people saying clopidogrel 75 milligrams.
Okay, let's see if we're right. Yeah, spot on. Clopidogrel 75. So from the history, he's got intermittent claudication, peripheral vascular disease. So he should therefore be prescribed some medications for the secondary prevention of cardiovascular disease. So this includes antiplatelet treatment of clopidogrel 75. And then if that's not tolerated, you could try aspirin 75. The reason it's not clopidogrel 300 or aspirin 300 is because these are loading doses and they shouldn't be prescribed daily. So an example of when you'd use aspirin 300 is in ischemic stroke. And then atorvastatin 80 milligrams would usually be recommended for secondary prevention, not 20 milligrams. Okay.
Would any patient
Yeah,
be considered for dual antiplatelet or not?
Generally, dual antiplatelet therapy, it isn't indicated here. Dual antiplatelet therapy may be indicated after an MI or a stroke, but it's generally monotherapy with an antiplatelet agent for, in peripheral vascular disease.
Okay, thanks.
No worries. Okay, so next question. 55-year-old lady with claudication is assessed and an ABPI is performed. Results show an ABPI value of 1.3. Which of the following conditions may lead to this abnormal result?
Again, some pretty fast responses on this one. I've got people saying diabetes.
Okay, let's see if we're right. Yay, got it right. So yeah, type 2 diabetes. This is because of the arteriosclerosis, so the calcification of the vessels, which make the vessels less compressible when you're measuring ABPI, which can give a falsely high reading. So that's absolutely right. Well done. We've got 3 more questions left. So a 75-year-old female presents with acute onset pain in her left leg. The leg is pale and cold with diminished sensation and muscle power. Before today, she has not had any leg pain. This patient has had a history of COPD and AF. She takes ramipril and bisoprolol long-term and recently finished a short course of prednisolone and clarithromycin for a respiratory tract infection 2 months ago. She's an ex-smoker with a 30-pack year history. A diagnosis of acute limb ischemia is made and she receives an emergency operation 3 hours after admission. Which one element from the patient's background and history is most likely to contribute to her presentation?
So we've got an answer in the chat. Someone's saying AF.
Okay, here we go. Spot on. So AF, the right answer. So AF is a risk factor for thromboembolic acute limb ischemia. Smoking is a risk factor for atherosclerosis. So that would be a risk factor for peripheral arterial disease. Remember, these are 2 different pathologies. The patient didn't have any previous claudication, so therefore an embolism is the most likely cause. So that's correct, atrial fibrillation. Okay. Last two questions. A 65-year-old man presents to his GP with bilateral burning sensation in the back of his legs after walking approximately 100 yards. The sensation is relieved by rest. His ABPI is 0.8. What is the first line imaging to investigate this patient further?
So we're getting people saying ultrasound.
Okay. Yeah, brilliant. So duplex ultrasound scan is the first line imaging in peripheral arterial disease. So this scenario describes someone who has peripheral vascular disease. Something like sciatica is less likely given the ABPI reading of 0.8. A CTA or an MRA and catheter-based angiography can be used to investigate those with peripheral arterial disease, but they're not first line. So they might be better, but not first line. According to the NICE guidelines, imaging should only be performed in people with peripheral arterial disease if it's likely to provide information that will influence their management, because we said that peripheral arterial disease is a clinical diagnosis. Okay, and final question, and then you can go off and enjoy the rest of your evening. A 78-year-old lady is found by carers with a severely painful left leg. On examination, she has no palpable pulses and the limb is cold, insensate and mottled. The mottling does not blanch with pressure.
So the chat is saying primary amputation.
The last question, here we go. That is correct, amputation. So well done for everyone who said that. So the reasons for this are that the acute limb ischemia has progressed too far by this point. So she hasn't got any pulses, pulseless, perishingly cold, paralysis, the skin's mottled and it doesn't blanch with pressure, which means that there's no blood filling the leg. So amputation would really be the only option there, or palliative approach. So well done. And that's it. That's the end of the PowerPoint.